Picture this. A 65-year-old man walks into your rural clinic. Heart failure, ejection fraction 32%. He's supposed to be on 4 drugs. He's on 1, and he's been admitted twice this year.
He's not unusual, is he? We have 4 drug classes that each independently reduce mortality in heart failure with reduced ejection fraction. Beta blockers, ARNs, mineralocorticoid antagonists, and SGLT2 inhibitors. And most patients in real-world practice never get all 4. In Australia, the numbers are just as bad as everywhere else.
Good morning. It's Saturday, the 8th of August. 4 stories today. A heart failure polypill that could change how we prescribe. A clean negative for hydroxychloroquine in recurrent miscarriage. A steroid-sparing biologic for polymyalgia rheumatica. And the first once-weekly HIV pill. Let's go.
Story 1. The polypill question. A new trial called POLEHF, published in Nature Medicine last month. The idea sounds almost too simple. What if the problem isn't which drugs to prescribe, but how many pills we ask patients to take?
PolyHF was run at 2 hospitals in Dallas, Texas, Parkland Hospital, a Safety Net County Hospital, and Clements University Hospital. The population matters. Median age 54, 54% black. A predominantly underserved population where adherence is genuinely hard.
212 patients, all with ejection fraction 40% or below. Randomized to a once-daily polypill containing metoprolol succinate, spironolactone 12.5 milligrams, and empagliflozin 10 milligrams, or individual drugs titrated separately. The ARN or ACE inhibitor stayed as a separate pill in both arms.
So it's 3 of 4 pillars in one capsule. And critically, the comparator wasn't just usual care, it was enhanced usual care. The study team actively helped titrate individual drugs, provided medications at no cost, and coordinated with the patient's own doctors. This was the polypill against the best possible version of individual drug management.
That's a fair fight, not a straw man. So what happened?
At 6 months, the polypill group had a 3.3 percentage point greater improvement in ejection fraction measured by cardiac MRI. The primary endpoint, statistically significant but barely, p-value of 0.039, confidence interval from 0.2 to 6.4.
Let me be honest about what that means. We're talking about moving ejection fraction from say 30 to 33. The confidence interval almost touches 0. Is that clinically meaningful or is it noise? Ejection fraction can vary by a few percent just based on who reads the scan.
That's the critique John Mandrola raised. Ejection fraction is a surrogate endpoint. Patients care about staying alive and out of hospital. But here's the harder endpoint. Heart failure hospitalizations and emergency department visits were 60% lower in the polypill group. Rate ratio of 0.4.
60% fewer hospitalizations. That's clinically meaningful by any standard. And the adherence data is the mechanism. They measured blood drug levels using mass spectrometry, not self-report. 79% adherence in the polypill group versus 54% in the individual drug group. A 25-point gap in confirmed, blood-tested adherence.
That's the real story. The drugs work. They've been proven in dozens of trials. The problem is getting patients to take them. Fewer pills, better adherence, fewer hospitalizations. The same principle that works for hypertension polypills.
But let me play devil's advocate. Even the enhanced usual care arm had 78% of patients on all 4 classes by 6 months. In real-world practice, that number is closer to 15%. So both arms were unrealistically good compared to actual practice. And the trial was small, single region, open label, 212 patients.
All fair. But for your heart failure patients who keep coming back with exacerbations, the message is practical. The problem may not be that they need a different drug. It may be that they need fewer pills. Use combination tablets where they exist. Synchronize timing. Think structurally, not just pharmacologically. A commercial heart failure polypill isn't available yet, but this trial will accelerate development.
Story 2. Something for your wife's obstetric practice. A woman has had 3 consecutive first trimester miscarriages. No cause found. She's read online about hydroxychloroquine. Her rheumatology friend swears by it. Should you prescribe it?
The Barbecue trial published in Lancet Obstetrics, Gynecology and Women's Health. A phase 3 double-blind placebo-controlled trial across 17 French hospitals. Women aged 18 to 38 with at least 3 previous unexplained first trimester miscarriages. Hydroxychloroquine 400 milligrams daily. Started before conception, stopped at 10 weeks gestation.
And the answer is no. Hydroxychloroquine did not improve live birth rates. 58% live birth in the hydroxychloroquine group versus 61% in placebo. Not only did it not help, the point estimate actually favored placebo. Odds ratio of 0.89. Completely negative.
The trial was originally designed for 300 women but was stopped early by the French medicines regulator after 2 cases of polydactyly in the hydroxychloroquine group. 169 women were enrolled. Of those, 125 conceived. 74 had a live birth. The numbers are small.
The early stopping is important context. The Independent Data Safety Monitoring Board concluded the benefit-risk balance remained acceptable, but the regulator overruled them. So we have an underpowered trial that was stopped for safety concerns that the safety board itself deemed acceptable. That's frustrating.
The accompanying Lancet commentary from Karen Schreiber in Copenhagen made exactly this point. The title says it all. Protecting women through research, not from research. By shutting down carefully monitored pregnancy studies before they can answer the question, regulators leave clinicians with no evidence either way. And in the absence of evidence, prescribing continues unchecked.
Which is exactly what's happening. Hydroxychloroquine is being prescribed off-label for recurrent miscarriage based on retrospective data and biological plausibility. The immunomodulatory and vasoprotective properties make theoretical sense. But this is the first proper randomized trial and it's negative.
Bottom line for your wife's practice. Hydroxychloroquine should not be routinely prescribed for unexplained recurrent miscarriage. The evidence doesn't support it. And the 2 polydactyly cases, while possibly simply coincidental. Add a note of caution. For now, supportive care and the existing evidence base for progesterone in some subgroups remains the standard.
Story 3. Polymyalgia rheumatica. One of the most common inflammatory conditions in patients over 50. You know the presentation. Bilateral shoulder and hip stiffness. Elevated inflammatory markers. Dramatic response to prednisone.
The problem is steroids. Patients relapse when you taper. They end up on prednisone for months or years. Diabetes, osteoporosis, fractures, cataracts. We've needed a steroid-sparing option for decades. Methotrexate has modest benefit. Now we have the REPLENISH trial, published in the New England Journal of Medicine in June.
Secukinumab, an IL-17A inhibitor already used for psoriasis and ankylosing spondylitis. REPLENISH randomized 381 patients with relapsed polymyalgia rheumatica to secukinumab 300 mg, 150 mg, or placebo. All groups got a 24-week prednisone taper.
The primary endpoint was sustained remission at 52 weeks, meaning no symptoms and no need for escape therapy from week 12 to 52. The results: 41% sustained remission with secukinumab 300 mg versus 20% with placebo, essentially double the remission rate.
And steroid exposure was lower. The mean adjusted annual cumulative glucocorticoid dose was 1,600 mg in the secukinumab group versus 2,100 in placebo. That's roughly a 500 mg reduction in prednisone exposure over a year, meaningful for diabetes and bone health risk.
John Stone from Harvard was the global principal investigator. He noted that this is the first biologic to show a clear benefit in PMR. The safety profile was consistent with secukinumab's known profile in other conditions. No new safety signals. Nasopharyngitis and hypersensitivity reactions slightly more common.
But here's the honest limitation. This was a relapsed population. Every patient had already failed at least one steroid taper. So the question of whether secukinumab helps newly diagnosed patients before they've accumulated steroid toxicity remains open. And IL-17 inhibitors aren't cheap. This won't be first line.
For your GP practice, this matters when you have that patient who's on their third or fourth prednisone taper and can't get below 5 mg without flaring. Currently, your options are methotrexate with modest evidence or just accepting chronic low-dose steroid toxicity. Secukinumab is now submitting for regulatory approval in the US, EU, and Japan. Watch for TGA and PBS applications. This could reach Australia within 12 to 18 months.
Story 4. HIV. We've been moving towards simpler regimens for years. From multi-pill protease inhibitor combinations to single-tablet daily regimens. Biktarvy, the standard first line, is one pill once daily. But once daily still means 365 pills a year. For some patients, that daily reminder is a burden.
ISLND1, published in the New England Journal of Medicine on July 29th. The first phase 3 trial of a once-weekly oral HIV regimen. 607 adults with virologically suppressed HIV across 12 countries, randomized to switch to once-weekly islatravir and lenacapavir, or stay on daily Biktarvy.
At 48 weeks, the result was clean. Not a single participant in the weekly group had a viral load above 50 copies. 93.4% maintained suppression in the weekly group versus 92.4% with daily therapy. Non-inferior. No resistance developed to either drug.
The mechanism is elegant. Islatravir is a novel nucleoside analog with multiple mechanisms of action. Lenacapavir is a first-in-class capsid inhibitor that disrupts HIV at multiple stages of its life cycle. Both drugs are potent enough and have long enough half-lives to work as a once-weekly combination.
Let me raise the caveats. This was a switch study in already suppressed patients with high baseline adherence. We don't know if weekly dosing works for treatment-naive patients or for patients with adherence problems. The paradox is that patients who struggle with daily pills might also struggle with weekly pills, just with higher stakes from a missed dose. And islatravir had earlier safety concerns with CD4 declines at higher doses, though the 2 mg weekly dose appears safe here.
Still, this is a genuine milestone. The first complete weekly oral HIV regimen. For patients with pill fatigue, privacy concerns about daily medication, or travel, this could be transformative. Regulatory submissions are expected. In Australia, this could reach the PBS within 2 to 3 years. Start thinking about which of your HIV patients would benefit most from a weekly option.
Quick hits. 3 items for your practice this week.
First, PBS September brand changes. From September 1st, multiple brand deletions including Amoxil capsules, Cardizem CD, Actos, and Polyvisc. Check your repeat prescriptions and transition patients to remaining generics before they hit dispensing errors.
Second, the ESC Congress runs August 28th to 31st in Munich. 59 late-breaking trials. Watch for Librexia ACS testing factor 11 inhibitors after heart attack and steri on statins in healthy adults over 70. We'll cover the practice-changing ones next week.
Third, TGA is consulting on new medicine label advisory statements. Celecoxib, naratriptan, and methenamine would get new warning labels, and immediate-release melatonin for jet lag would get its first RASML entry. The consultation closes September 4th. Worth knowing if you prescribe these.
Recap. 4 stories. 1. Heart failure Polypill, POLIHF showed 60% fewer hospitalizations via better adherence. Simplify your heart failure regimens. 2. Hydroxychloroquine for recurrent miscarriage, negative, don't prescribe it. 3. Secukinumab for relapsed polymyalgia rheumatica, double sustained remission and cuts steroid exposure. Watch for TGA approval. 4. Once weekly HIV treatment, non-inferior to daily, the first weekly regimen in history.
See you tomorrow. Stay sharp.